presenter is Jack Cuzick, co-chairman of the International Breast Cancer Intervention Studies, and he's going to present the 10-year results of the International Breast Cancer Intervention Study 2. Jack.
Thank you, Kent. It's a pleasure to report the long-term follow-up of this study. This is an enormous study with over 200 centers involved across about 18 different countries. Basically, the disclosures are given here. The only thing that's really relevant in the study was partially funded by AstraZeneca, who make an anastrozole, but they had no involvement in the management, running, or decision to publish this data. So we published about 6 years ago the initial results of anastrozole in prevention, and the aim of this study is a particular focus on what happens in the longer term. That original publication was five-year follow-up, median follow-up, and now we're up to almost 11-year median follow-up. So substantial information about the long-term data. Particularly relevant because tamoxifen has been looked at in prevention and been shown that the 30% reduction you get with tamoxifen for 5 years is maintained for at least 20 years. So that's a crucial question for the aromatase inhibitors. So the study design was just under 4,000 patients or women, 68-64, randomized 1-to-1 to either anastrozole, 1 milligram daily, or matching placebo. The first 5 years they were followed up in clinic while they were given treatment. And then the subsequent follow-up was a bit of a mixture depending on the country, clinic visits, questionnaires to the patients, and in some cases we were able to supplement that with registry data. So the median follow-up now is 10.9 years on that particular data. So the results are here. Previously we only had half the patients out to 5 years. This is the full, complete data for everyone out to 5-year follow-up. And there was a 60% reduction, a 61% reduction in new breast cancers over that 5-year period, going from 4.6% down to 1.8%. And the number needed to treat to prevent one breast cancer in that first 5 years is 36, which is pretty good. So the new data basically looks more at the long-term follow-up. The effect size was not quite so big, although it was not significantly lower. It was a 36% reduction in new cancers in years 5 to 12, going from 4.4% down to 3.5%. Statistically significant in its own right, and although numerically less than in the active treatment period, not significantly so. And so if you put that all together, you end up with a substantial benefit over 12 years. 49%, almost half the breast cancers were prevented, reducing that from 8.8% down to 5.3%. And the number needed to treat with that 12-year follow-up now drops to 29, which is substantially bigger than what was seen with tamoxifen at that stage, where you needed 49 patients to prevent one breast cancer. So 5 years of treatment, remember treatment stops at 5 years, carries on producing continuing benefits right out to 12 years, and follow-up will continue. A little bit of subgroups. If you looked at the effect first 5 years versus after 5 years, there was, as I pointed out, a bigger effect in the first 5 years, but still a significant effect subsequently. The effect was stronger, as we expected, in estrogen receptor positive cancers, but we found a somewhat surprising, although non-significant effect of even a reduction in estrogen receptor negative cancers, which was actually apparent in both treatment periods, although not significant. So this is going to require further follow-up to see whether there is potentially some effect in cancers which arise as ER-negative cancers. A big effect in DCIS, the essentially precursor lesion to cancer, a 60%, 59% reduction overall. And it was apparent particularly in the first 5 years, but continued to show up after that period. So a substantial reduction in these early lesions. And although we didn't have estrogen receptor assays on all of the DCISs, that's not routine, in the ones for which we did, we found a really dramatic, almost 80% reduction in new cancers. And that was equally seen both in the first 5 years and subsequently. Adverse events were really reassuring. There was really nothing serious. The mortality data is still too early. It's 69 deaths in the anastrozole versus 70 in the placebo, and only 2 versus 3, 1 less death in anastrozole, but way too early. So we need another 10 years of follow-up to actually sort out how these dramatic reductions in incidence are going to convert into mortality or not. In terms of other cancers, we had expected a reduction in endometrial cancer, which we didn't see because it was so estrogen dependent. Numbers are small, but we found a dramatic reduction in skin cancers, mostly non-melanoma skin cancer, for which we don't have an understanding, but a 40% highly significant result in a reduction of those cancers as well. The other issue is we did look at treatment adherence. Every patient had had their full 5 years, offered full 5 years of treatment, and the differences were very, very small. So 77% of the placebo arm continued to take treatments for the full 5 years, and it reduced to 74.6% in anastrozole. So just about 2.5% higher dropout rate. And I think that's what you can attribute to the side effects. We did report in the first result in the 5-year period, there were a lot of reported side effects, particularly musculoskeletal events. It was 64% in the treatment arm, but 58% in placebo. And I think one of the real challenges is that most of these effects that are actually being reported are not treatment related. There's a very, very high rate of musculoskeletal arthralgias, even in placebo arm, indicating that we have to be very careful to interpret this. And in fact, the loss of continued treatment for the 5 years is really very, very small, just this 2.5%. So I think that's an important issue. No serious late events as well that we've seen. And I guess also no increase in fractures. The fracture rate was known to be high with estrogen depletion in the treatment trials. We required a baseline DEXA scan in all the patients, and they had to take a bisphosphonate if they are osteoporotic, and it was recommended if they are osteopenic. No increase in fractures, just a tiny 4%, nowhere near significant increase. So that problem seems to be manageable. So just in conclusion, anastrozole significantly reduces breast cancer by 49% with the 12-year follow-up. It's particularly clear in the ER positive, but some effect in ER negative, which we still don't understand. And the important new data was a substantial 36% reduction seen in the post-treatment period, which is still larger than seen for tamoxifen, which is about a 30% reduction year on year, but it goes out to 20 years. We see a much bigger effect in the first 5 years and a continuing effect which is larger in the post-treatment period. So that's, I think, good news as well. The number needed to treat is only 29 now. That's after 12 years of follow-up, which is a very respectable number, bigger than what was seen for, or lower than was seen for tamoxifen, a bigger effect there. No increase in fractures. Again, baseline DEXA scans, I think, were important to identify women who were osteoporotic initially and make sure they got treated. They could still take anastrozole, but they needed a bisphosphonate as well to protect against fractures. There were really no major adverse events seen between the treatments. The other cancer effect was very, very similar, aside from this reduction in non-melanoma skin cancers, no increase in cardiovascular events, as I said, no increase in fractures, and we could find really no serious side effects. And of course, the ones that occur in the first 5 years are things like musculoskeletal pains. We weren't able to follow that up properly in the follow-up period, but most of those occurred within about a year or two, so we don't expect that we've really missed anything serious there. And the mortality data is still immature. There's no effect on breast cancer or other deaths, but it's way too early to make any judgment about that. I think this highlights the real important need, particularly in prevention studies, to do long-term follow-up. We've learned a lot going out to 12 years. Another 10 years of follow-up will tell us a lot more about the impact on mortality. So in conclusion, I think these data provide further support for the use of anastrozole in breast cancer prevention in high-risk women. It's been recommended by NICE in the United Kingdom, National Institute for Clinical Excellence, and the U.S. Preventive Task Forces in the United States, but it's not licensed for treatment because the drug's off patent and nobody wants to pay those extreme fees, but it is being used, although not as much as we'd hoped. So thank you very much.
Jack, if I could ask.
Yeah.
Well, go ahead and ask your question.
You first.
I should put it
How many patients, what was the difference between the bisphosphonate use between the treatment arm and the placebo arm? The reason I ask is I think there is some data that bisphosphonates may also reduce the risk of breast cancer, and I wonder if that could explain partially the result.
Possibly. Bisphosphonate use was not common, and it was decided up front before treatment randomization. So there's no major difference. We haven't looked at that in huge detail, but there's nothing really strong there.
Yes.
Bruce Jansen, MDH Oncology. Two, I guess, unrelated questions. Your thoughts on how in the world the drug could reduce the risk of skin cancer?
Well, that's a really good question. The results are very, very strong, so they're not likely to be chance. This is a highly significant difference. But the mechanism for how aromatase inhibitors might reduce skin cancer is, to my mind, completely unknown.
And what happens to self-reported joint pain in the years after going off the drug?
We don't have that complete, but most of that shows up in the first year or so. And the fact that during treatment, and we kept that, we did check that annually during the treatment. We didn't have that routinely collected post-treatment, but in fact we found very few new reports where it was reported. It was collected in a few countries. Most of this occurs in the first year or so, and the fact that the number of patients that dropped out in that arm was so small indicates that it was not a major factor later on, although we don't have long-term data routinely.
So is the understanding that it usually appears in the first year or two and then fades as a problem even on treatment?
What we've seen thus far is it basically occurs within 3 months of starting treatment. Some patients it's quite severe and they need to stop treatment. Not it will be severe, but in many of the cases, over about 6 months, it disappears or is accommodated and it doesn't cause problems.
Marisa Weiss, breastcancer.org. Just building on that, just the quality of life. I mean, the implementation, sort of the patient interest in doing preventative anti-estrogen therapy is sort of low, and they're fearful of the side effects, not necessarily adverse effects, but just the quality of life. And in terms of hot flashes, and as you were talking about musculoskeletal symptomatology, do we collect PROs on these, and what can we tell a patient today about the impact that this medicine might have on their quality of life?
We have collected that during the active treatment period and know that fairly clearly. There are clearly effects that do affect quality of life. It's typically seen mostly in the first 3 to 6 months, and by a year we don't see very many new reports of these outcomes. And as I said, most patients have carried on the treatment for 5 years, so not been that serious, although we have to accept that that is an issue. What I think is particularly striking is the fact that these things are very common in the placebo arm. And one of the problems, I think, in terms of perception is that certainly in a non-controlled situation, this all gets attributed to treatment, where in fact, as I said, even the musculoskeletal effects, it's 58 goes up to 64%, and it's a smaller impact on hot flashes. So much of this is just aging. I think if I could blame my aches and pains on a drug, I certainly would, but that's, I think we have to recognize that much of this is not treatment-related, but age-related, and it's a challenge as to how we get that message out there.
Well, the adherence rate in this study is so high that the patient population in this study is particularly highly motivated and committed to participating, and I'm not sure that high level of determination is present in other women at high risk who didn't participate.
I think that's a fair comment, and we need to learn how to manage that.
So your preventive effect declines somewhat over time, in your later years.
Yes,
So,
cumulatively,
but
yes.
with risk of breast cancer in these women would only be increasing, right, because they're getting older.
Correct.
So could you, I know you don't have the data, but could you imagine that if you had kept them on this continuously, that you would have had an even bigger difference?
Well, that's an important question because the effect in the post-treatment is still bigger than tamoxifen, but not as big as the active treatment. So it does raise questions as to whether or not we should consider, either longer treatment or some kind of intermittent treatment. And I think what would really be nice would be to have some kind of biomarker which says who needs that. At the moment, we're looking at a few things. Breast density is useful, but not so much for postmenopausal women. It's going to be difficult to run a big trial of that, but if we could find biomarkers that were useful, we
Right.
could maybe identify those that might benefit more from longer treatment.
Well, now you have breast cancer-associated genes, not just BRCA, but all these other ones
Sure.
too. So, I mean, if you were designing this today to be really sophisticated, wouldn't you perhaps look at genetic profile? And see
Well,
who's
we
at
will
risk?
be doing that. We have all the bloods on them, and our intention is to look at all the SNP profiles, to look at all of the genes. So that will be further work that we'll be looking at.
Oh, that'll be interesting.
So it's very important, not only for for treatment effects, but can we identify those at highest risk of side effects? We hope to be able to do both of those things.
Great, thanks.
To your point about the, if you'd kept the drug going longer, we get some data from that for the extended adjuvant therapy in breast cancer, looking at contralateral breast cancer. If I recall, there was further reduction in contralateral breast cancer with the extended aromatase inhibitor in those studies. Is that your
That's correct,
recollection?
but those are usually, they're not quite pure study because there's a tamoxifen first and then an AI in most of them. Though AI only ones, there isn't a lot of data on that, but it's not unreasonable to expect that there may be continued benefit by longer treatment. So it's an open question still.
2 years ago at this meeting, the Viennese investigator reported that you'd get no further benefit once you continue past 7 years of aromatase inhibitors, so you don't need to go to 10, and we reported that at Medscape, and it was widely reported at the time. So it looks like 7 years is all you need.
That's for the adjuvant setting in women with breast cancer. It may be slightly different for the preventive therapy.
Oh, okay, thank you for
So
clarifying
it's
it.
still a little bit, there's still some uncertainty there.
Okay.
Oops.
Okay, if there are no more questions,